Okay, once again, I'd like to welcome everybody. My name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. I'd like to welcome everybody to our E&M spring cleaning series, Polishing Your Level of Service Knowledge. So this is the first in a two-part series this week that is meant to be kind of a beginner's course, more of a higher level overview on choosing your E&M level of service. Today will be an overview of choosing your level of service in general, and tomorrow Ashley's going to be leading an interactive session. And by interactive, we are going to be asking you to participate. Her session is going to talk about common denials and rejections that are related to issues with choosing the level of service. And then there's also going to be an interactive activity that's going to allow you the opportunity to apply the knowledge from today, further solidifying how to choose your level of service. And as I mentioned, this is an overview and it's geared to get you the basics of choosing your level of service. We received several questions asking for some absolute answers on particular scenarios and codes. And how we can take the gray out of choosing your level of service. So some examples, again, lists of CPT codes that are always considered moderate or high level, lists of diagnoses that are always considered moderate or high level. Unfortunately, there isn't a definitive list that exists. The reality is choosing that level of service is very subjective and it varies greatly based on the patient situation, their needs, their conditions, and what's happening in that encounter. What are you doing for that patient? So what we hope to accomplish today is to provide you with a better understanding of how level of service works with evaluation and management or E&M services, just with the goal to help you better navigate those gray areas when you're choosing that level of service. So to accomplish this, I'm going to do a couple of things today. We're going to be walking through just an overview of what level of service is, how you choose it using time and medical decision making. We're going to talk about the different elements of medical decision making, and we are going to define those levels of service. And along with that, I'm going to be talking about some documentation. Again, this is going to be an overview because there are those gray areas depending on the encounter. But we're going to provide some examples throughout this session today to hopefully help you with that. Now, to further support our goal today, it goes beyond today. I want to make you all aware that Ashley and I have multiple series scheduled for the upcoming months, which are going to take us beyond this overview and this beginning step. We're going to be drilling down into each component and provide a more in-depth training for that. So we're going to be doing a series specific on using time. We're going to talk through the medical decision making, the various elements of those. We're going to break down those components, and we're also working with our clinical staff to help get us some more examples of what some of that documentation may look like. Again, there's gray areas. It's not going to be a one size fits all, but we want to get you those tools. So stay tuned to our live events page for registration for those upcoming events, if any of that interests you. So with that, let's go ahead and get started with an overview of just the concept of choosing your level of service. So first and foremost, with any Medicare service, the first determinant of coverage is going to be whether or not the service is medically necessary for the patient. So per the Social Security Act of 1935 in Section 1862, services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. So this is all going to be based on your documentation. This is what the reviewers first and foremost are looking for when a claim or a service that's been billed comes under review. What they're looking for is, what are you doing for the patient? Is it reasonable? Is it medically necessary? Why does the patient need your service for this encounter? We need to understand that. This is also what they look at for RAC audits or CERT audits. They're looking for that medical necessity first before they look at the level of service. So that's first and foremost. It also needs to be a service that's not statutorily excluded. And so it all comes down to that documentation. What does that documentation support? Does it support what was billed on that claim? We also need to consider new versus established patient. This is a common denial that we see. It's a situation where a new patient service is being billed when it really should have been an established patient. So, what is the difference? Medicare allows for a new patient visit if that patient has not been seen or received services in the previous 3 years by the same physician or member of the same group with the same specialty. So, if you have multiple internal medicine providers and they are in the same group, they are different people, but they are in the same group with the same specialty. So if you have a patient that starts with one of those internal medicine providers and then the next visit sees the second one, that is still technically an established patient. It's not necessarily a new patient simply because they saw a new provider in your office. Now, if it's a different specialty, and we use primary specialty that is designated during that enrollment process, it could be that they're a new patient to that provider in that group with a different specialty. Like I said, we use that primary specialty, and we do get questions about taxonomy codes and secondary specialty. The way the adjudication system is designed, it does everything off the primary specialty. If you have two providers with the same primary specialty, but one of them has a different secondary, and that's what you're wanting to bill that claim for, it is going to be denied and would have to be appealed, and you can show that specialty. We also get this question a lot for our non-physicians, particularly nurse practitioners and physician assistants. With those non-physician practitioners, because they don't declare a specific specialty outside of that NP or PA specialty, we do have our system set up to edit for the narrative section where they can actually call out, say they're a nurse practitioner that specializes in cardiology or a physician assistant that specializes in nephrology. They can spell out those areas of specialization to help that claim go through the first time. So keep that in mind. Taxonomy is the other one that we do get questions on. That taxonomy code is part of registering for an MPI, and it is in their enrollment record, but it is not part of identifying the specialty in that enrollment record and through the claims adjudication process. It is taxonomy is a lot more about that MPI process. The other situation that we see often is when a provider moves to a new group. So if you have a provider that is at group A and they saw a patient at group A, that provider moved to group B and they saw the same patient at group B, if it's within the last 3 years, even though they are with a different group, that patient is still an established patient for that provider because again, it is about that provider's MPI. It's not about the tax ID that they're affiliated with. Our providers do tend to practice with multiple groups, so it is about that provider themselves and not their group affiliation. Here I've also included just a screenshot of the chart that is included in the CPT to help you with that. It's a decision tree that may be helpful to you. Okay, levels of service. So to start, the AMA, I want to call out that the American Medical Association does own the description of the procedure codes. Medicare, CMS, we do not own those descriptions. In those descriptions, it does call out levels of service based off of MDM or the amount of time. So that is something that we are following those descriptions. So when you're choosing your level of service, the majority of the time, you are going to have the option. As I said, the descriptions include time and the level of medical decision making. You can choose between time or MDM. That is up to you, and you want to choose the one that makes the most sense for your encounter. I do want to count out or call out though, there are two two services that you always have to use time, and that's going to be for anything in the emergency department and critical care. Those are generally higher levels of medical decision making anyway, and so CMS is requiring that or NAMA are requiring that you use time for those. When you're selecting your level of service, most categories of services are going to have four levels: straightforward, low, moderate, and high. While most of them have four, you are going to notice in the CPT that some only have three, and that is because they've combined low and straightforward. They're maybe very, very similar. There's no need for that second one. My apologies, I had a tickle in my throat. I did not want to cough in your ear. Um, when you are determining your level of service, and we're going to go through those in a minute, you must meet or exceed two of the three levels for the components or elements that are in that level of service. And as I said, we're going to be going through that in a few minutes. But again, I want to point out that your documentation is going to need to support the level of service that's being billed. And you want to make sure that you're using time or MDM where you have the choice, where to your advantage. Don't leave money on the table. You may have a situation where it's the question we get is should my office always use time? Should it always use MDM? It can be an office decision. It can be a patient by patient decision. It can vary. You could have a 30-minute office visit, which if you look at the CBT, it codes at a low level based on that 30 minutes. But if in that 30 minutes the MDM was significant and very complex, it is possible you may have documentation to allow you to bill for a higher level of code. The provider did the work. CMS Medicare wants to reimburse the provider for the work that they did. So what we have seen as a best practice, and it's not a requirement, but we've seen offices where we know they are tracking both time and the medical decision making so that the best decision can be made when it comes time to bill. So we'll start with time. Time is generally fairly straightforward. Uh, the time is identified in the code descriptor, like I gave an example where a low level may be 30 minutes, but the code descriptor will indicate that to bill for this code, you must the meet the minutes that are laid out in that descriptor. So when using time, you're looking at the time that is spent on that same calendar date. So make sure you're looking at that, and you do have to meet it. Uh, it is going to include face-to-face and non-face-to-face time, which we'll talk about in a minute. Again, you're doing the work. Make sure that you're accounting for all of the work that's being done for the patient. If you don't, you may be leaving some money on the table that you're entitled to because you have done that work. That non-face-to-face time can sometimes be significant enough that it changes the level of service uh, compared to what was done with that face-to-face time. Um, the time is the time that the practitioner spends working for that patient or that patient's care. It's not going to include the ancillary staff. So just make sure that you're looking at that. CMS does have some information, and I've provided this link in the resource section, but it does have information on accounting for time in the claims processing manual, chapter 12, and it's in section 30.6.7.g. And again, that's included in your resources section, so you don't need to remember that. But when the MACs are reviewing the documentation for something that's been chosen by time, the documentation needs to be specific and it has to make sense. So as far as being specific, it can't be I spent 15 to 45 minutes. It has to be a specific time. You want to stay away from ranges. That's not going to be your best practice, especially if it spans a couple of codes. We're not asking providers to have a stopwatch and keep track of every second that they're with the patient, but you should know the time that you started with the patient, the time that you ended, and the amount of time that you spent on those non-face-to-face activities. And then again, it has to make sense. If you have 60 minutes and somebody is coming in with a cold, does that make sense? Did that really take 60 minutes? So you just want to be cognizant of the time that's being documented, making sure that it's clear so when that reviewer looks at it. So let's look at what can be counted. We're going to start with the activities that are non-face-to-face time that you can count towards that visit. Uh, Again, documentation, the practitioner does have to document the activities and the amount of time that they spent on it. It's not a stopwatch, but they can't just say documented chart and us as a reviewer, know how much time they spent on that before. So make sure that that is clearly documented in there. So the types of non-face-to-face time that they can include preparing to see the patient. Maybe they are looking at notes from the previous visit. That time does count. Maybe they had to coordinate some things uh, to discuss with that patient. That time does count. If you're looking at that separately obtained history, maybe it's a conversation with a family member because the patient is unable to give their history. Maybe they're non-communicative. Maybe they have some cognitive issues, which makes their account of the history unreliable. This isn't maybe also talking to the family member, but this is actually obtaining that history separately from them. Performing the performing the exam. Now, typically that's going to be face to face, but that is something that can be counted. Ordering medications, tests, any procedures, that all counts as long as it's being done by that practitioner. If you're setting up any referrals or you're communicating with other healthcare professionals, where those healthcare professionals are not going to be billing for that separately, those could be counted as time. You're not going to count it twice. So, and you'll hear this a couple of times today. If something is being billed separately and reimbursed, it's not being counted twice. There's not, we're not going to allow for double dipping. If the other non-face-to-face time that can be counted is going to be the documentation of that encounter. So they're charting, they're doing the medical notes. Again, as long as the practitioner is the one that's entering that information themselves, that is time that practitioner spent doing that. And then you're also going to be able to account for any results that have been independently interpreted by the provider. Again, independently interpreted, there does need to be a report for that. It's maybe not going to be the same as what the radiologist may have in their report, but it has to be an interpretation and account for their findings. It's not, I reviewed the radiologist's notes and I agree. That's not an independent interpretation. Okay, just so that you have that distinction. And then also any care coordination. This could be where you're interpreting results and communicating that with the patient, the family, their caregiver. Again, when not separately reported, depends on what's going on for that patient. You want to make sure that you're cognizant of the fact that if it's being billed separately, it may not be time that you're counting. Things that you do not want to count. You're not going to count performance of those services that are separately reported. You're not going to count travel time. This will come into play more so if, say, you have a home visit, the time spent traveling to the patient's home for that visit, that's not going to be counted. Any teaching that is general in nature and it's not specific for the management of whatever's going on with that individual patient, that is not going to be time that is counted as far as non face-to-face time. If the other thing is if you're engaging in conversations with other practitioners, or that, again, that's that communication we talked about, that can count. But if you are having conversations with the patient that is outside of what's going on for the patient in that or that encounter, maybe you're talking about fishing, maybe you're talking about books. Ashley and I, we work with Medicare, so certainly sometimes we will get questions about things that are maybe going on in the program. That's not going to be time that's going to be counted in determining the level of service. So moving on to MDM, AMA guidelines are going to show that medical decision making is made up of three parts. And those parts include the problem. With problem, we're talking about the number of problems that are being addressed in that encounter. So it may or may not include every problem that the patient has, but what's being addressed in that encounter. And we're going to talk about problem data and risk a little bit more. We'll break them down here in a couple of minutes. With problem, we're also looking at the complexity of the problem that's addressed, and could be unique to each patient. MDM is also based on data, including the amount and complexity of the data to be reviewed and analyzed for the medical decision making for that patient's problem in that encounter. We're also going to be looking at the risk of of complications to the patient of the decisions that are being made. That could include morbidity, mortality, all of that. What's the risk to that patient from the decisions that are being made in this encounter? So we'll start with problem. So the AMA defines a problem as a disease, condition, illness, or injury symptom, sign of finding a complaint, or other matter that is addressed in the encounter. And you'll hear me say addressed a lot. It has to be what is being addressed in that encounter. You may not have a diagnosis at the time of the encounter, and that is okay. It's not tied to a diagnosis. The level of service is not tied to a diagnosis, but the documentation does have to show what problem was addressed in that encounter. So the patient may have multiple problems. Maybe they have diabetes and hypertension, but they came in for a rash on the elbow, and that is the only thing that's being addressed. That's going to be the only problem that's counted that day. If you didn't also address the diabetes and the hypertension, they don't count as problems for that particular encounter. Now, if the rash on the elbow is from some treatment or somehow related to the diabetes or the hypertension, and you have to address those as well, they could count. So it's really coming down again to that documentation and what the practitioner and healthcare providers are telling you that they're doing in that session. The complexity is going to be specific to that patient in that moment in time. There are 4 levels. You have straightforward, low, moderate, and high. And we'll start with straightforward, which is typically going to be this self-limited or minor problem. So when you're looking at the CPT, you'll see this category in their level of service chart that they have. This is something that is definite and has a prescribed course. It's maybe transient in nature, and it's not likely to permanently alter the patient's healthcare status. It's a minor problem. Examples include things like a cold. Maybe they have a sinus infection, again, that rash on the elbow. But as I keep saying, it could be different for the patient. An example would be if you have a patient with severe COPD, so they have pulmonary disease, a cold could be a very major problem for that patient. Whereas somebody who doesn't have any other underlying health conditions, a cold is self-limiting. So you do need to look at the patient as a whole, and with a cold, they may also need to address the COPD, but they're going to need to include that information in that documentation when selecting that level. So a low problem is defined as 2 or more self-limiting conditions. Maybe they have a cold and just dermatitis, something benign, it's a self-limited problem. That would escalate this to a low problem because they have 2 or more self-limited. Okay. They could be a patient that has one stable chronic illness. One of the pre-submitted questions that we got was related to the definition of a chronic illness. A couple of things. It is not necessarily specific to a diagnosis. However, if you look out on CMS's website, their chronic care management MLN article does include some diagnoses that are typically recognized as chronic. But chronic is defined as a condition that's expected to last at least 12 months or until the patient's death. Okay, and it's going to be something that places the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. So you're going to have to look at that with the specific patient in that documentation to see if they manage it. We've gotten questions that said they have to have had it for at least 6 months. That's not how CMS is defining it. It has to be expected to last at least 12 months. So there's not a timeline before it can be counted as chronic. The other question that we get is, do I need to list it as chronic in the documentation? Now, certainly that could be a best practice, but CMS does not require that. It just needs to support the definition. And again, it's not solely based on the diagnoses, though there are some that are, typically understood to be chronic, but we need that documentation to support it. That medical record is going to determine whether it's considered chronic or not. Acute uncomplicated illness or injury, this could be a patient with a cold, but maybe the over-the-counter medicine isn't helping. So maybe the provider's having to consider steroids or other medications. It seems like a straightforward problem, but yeah, they've tried some things and it's not working. Could be that you have a patient that has a rash. Maybe it's spring. Poison ivy is everywhere in my area. So maybe they've got poison ivy, but the itch and the rash are not resolving, so they may need more intervention from the practitioner than would be typical for a self-limited problem. Also, one is stable acute illness. This again, I'm going to use sinus infection. Patient has a sinus infection. Practitioner started the treatment, and while it's not totally resolved, the patient is responding as expected. That would be an example of an acute stable. They're not getting worse. They don't need more intervention. We're just status checking and seeing how it goes. The last one here is going to be an acute uncomplicated illness or injury that's requiring a higher level of care. This could be a recent or new problem with low risk of mortality, which is why it's a low problem. It does require treatment, but they are expected to fully recover without functional impairment. In this situation, though, hospital or observation care could be required. You could have a patient, say, for instance, that's presenting to the ER with confusion, they're dizzy, they indicate that this has been going on for a couple of days and they are dehydrated, so they need IV rehydration. The practitioner is ultimately going to make this decision, and that's going to be reflected in that documentation. So a moderate problem is going to be one or more chronic illnesses with exacerbation. So they're not at goal, they're getting worse. Something needs to be, they need additional supportive care. Maybe they have side effects that require attention. So that's what that's looking for. It's not just the presence of the chronic condition, but it's not stable. Okay. It could also be that you have two or more stable chronic conditions. So maybe you have a patient with hypertension and diabetes. They're at goal, they're stable, but they have two chronic conditions. We need to be looking at that. It's a little higher level of cognitive load in that decision making. Could be that you have an undiagnosed new problem. So it's something that's not in their history. It's uh, it's just coming up. You don't necessarily know what it is. You're ordering additional testing. Again, remember we talked about where you may not have a diagnosis when you're determining the problem. It can be a condition, a complaint. What's being addressed? It's an undiagnosed new problem. We know they have back pain. That might not be just because of the back. That could be something with their kidneys. We don't know for sure what's causing it. That'd be an undiagnosed new problem. You could have an acute illness with systemic symptoms. So think respiratory problems, cardiovascular problems. Um, those are the types of things that you're looking for. It's impacting an entire organ system. And then also you have one acute uncomplicated. This is typically could be an injury, okay? That you're going to be, but it's complicated. Maybe they have a broken bone and maybe it's a complex break, something of that nature. Again, depends on the patient. High level of problem. Sorry, that jumped. This is going to be a chronic illness with severe exacerbation. We talked about chronic illness with exacerbation, but maybe it's not severe. It's being easily documented, but severe exacerbation. Typically, it's probably going to need an escalation in care, but the documentation needs to support that. We also are going to be looking at one acute chronic threat to their life or bodily function. So you want to look at what their situation is. Some examples would be sepsis, maybe they have COPD and they have severe breathing problems. Maybe there's wildfires in the area and the smoke is significantly exacerbating that condition. Sepsis obviously can be a very serious condition, and maybe they're having cardiac issues as well. That's all going to come down to the documentation and the medical decision making of the practitioner. Next, we're going to look at data. Now, this is going to be data that's analyzed in the treatment of that patient. What are you doing for that patient? It goes back to it's proof of thought. The documentation is telling us why the provider did what they did for that patient, why it was medically necessary. It's again that proof of thought. They're reviewing and they're analyzing the test results to help determine the care plan for that patient. Now, same categories here. We do have straightforward, which is going to be that minimal or no data that's used. There's limited data, there's a moderate level of data, and there's a higher and extensive level of data that you may run into. And that's going to depend on what's happening for the patient. So with the categories, they are based on the level of care. And here I've given you a screenshot from the CPT just as an example. So each category, if you look at it, is going to show an increasing level of care, an increased level of review. It's going to be an increased level of analysis. And the CPT is going to list the requirements for each level, and we're going to talk through those like we did with problem. But the categories are going to call out the number of data elements that must be met to meet that particular level. So for instance, if you're looking at, I'm just going to point to it here, if you're looking at the limited image, you must meet at least one of the two categories listed. You need to meet the category in full. It can be either category, but you need to meet one of those categories. With moderate, you have to meet at least one out of the three categories, and the categories outline the requirements. So again, you're looking at the entire category, not just part of it, and you do need to meet that in order to utilize that level or count that level of data. I do need to talk about what is considered a test, because that's typically the data that's going to be used. A test is defined as it could be imaging. It includes imaging where there's an independent interpretation by, say, their primary care provider. But as I said before, you do have to have a report in there. It could be lab work. It could be psychometric, or it could be physiologic data. Okay, as long as that data is not being billed separately, we're not counting it twice. One exemption I do want to count out a call out is going to be pulse oximetry. This is actually called out in the CPT and does not count as a test. Before I move to the next slide, I do want to talk about a pre-submitted question that we received that I think fits in well here when we're talking about counting. We got the question asking if the review of a three-way view x-ray counts as 3 data points. The answer to that is going to typically be no, because that is one unique test. That 3-view x-ray has one code. That's going to be counted, and this ties into our next topic. If there were 3 separate x-rays, that could count as 3 data points. So we're looking at unique tests, which brings us into our definition of unique. So the AMA states that if you're ordering and performing the test, you are going a test that is part of the same group. It doesn't count separately. And they say that because an overlapping test is not unique. A unique test is by that procedure code. And particularly with labs, you may have a lab panel, a CBC panel, say, that is ordered, and then maybe you order some of the single tests inside of that panel at the same time. You need multiple results. It's a separate CPT code provided. It does not count every time you do that. It's by CPT code, and because that separate test is included in that panel, it's not being counted multiple times. So you want to make sure you're looking at that. Going back to that x-ray, a 3-view x-ray is one CPT code, so it's one unique test. If there were 3 separate x-rays not included as part of one CPT, that potentially could be 3 data points. So you want to look at that. AMA also talks about unique source. So with a unique source, they are looking at that as a physician or other qualified healthcare professional that's in a distinct group or they're of a different specialty, or they're in a different entity. And I do call out subspecialty here as well, but that's all going to have to be very, very clear in the documentation. That's a unique source. When does this come into play? You might be reviewing results from previous medical records. It could be tests that were done in the ER, and you're reviewing everything that happened in the ER. That's going to be one source. So if you're reviewing materials from a unique source, it counts as one, not every test that they ran at that source. External, this is not reviewing your own previous notes. These are results, and it's information coming from outside of your facility or a member of your group, but with a different specialty. So they are a unique provider. Again, we're looking at specialty there. So external records or communications and test results are from an external provider, or a healthcare professional, or a facility or a healthcare organization. You're typically not going, this isn't going to happen if you're in the same group and have that same specialty. So it can include practitioners that are part of an organization or that are practicing independently. It could also be from a facility, such as a hospital, nursing facility, home health agency. So you want to make sure that you're looking at all of that. Discussion is something else that counts as data. So this is a real-time discussion between practitioners. So an example could be that you have a cardiologist that's discussing an aspect of the patient care with an internal medicine or their primary care provider. As long as this is an internal, interactive and exchange of information about that patient, it could be counted as data. It can be asynchronous, so it doesn't have to be on the phone and you're or in person, but it does need to be a short period of time. CMS doesn't define the short period of time, but it's not going to be weeks and weeks and weeks. Okay, it does have to be direct communication, and it has to be an appropriate source. So the example that we gave is to physicians that are having that conversation, or to medical professional. It also doesn't need to be on the date of the encounter. So this could be something you met with a patient, I need to consult with a cardiologist, and then you get back to it. So it may happen the next day. This is also something that's only counted if you're using it in MDM. We did talk about some collaborations and coordination of care. That's a little bit different. So just keep that in mind. So looking at data, we're going to start with straightforward. So straightforward is you're using very little data, so it's minimal. There may be no data. Typically, this is going to be a situation where someone comes in, yep, you have a cold, it's just got to run its course. No tests were ordered, no tests were reviewed. This is going to be straightforward. Low is going to be just a little bit more, obviously. You do need to meet requirements of at least one or two of the categories for tests and documentations that are reviewed. That means you have to have at least two. There has to be that assessment requiring independent historians. So you have to meet those categories. We do get some FAQs on this. So AMA has actually also created an FAQ that I have included the link here that goes into some specific scenarios. Moderate, that is one of three categories. In the moderate portion of the chart, you do have to meet those moderate categories. So for test documents and independent historian, it's going to require three of the items in that. Again, not three separate bullets, but three things. So you might have three tests, but no independent historian. That's three tests. So keep that in mind. It doesn't have to be every bullet in the category, but you have to have the amount that it's asking for. There's also category two, which is that independent interpretation of a test. We talked about it. It's not necessarily going to be at the same level of a radiologist's review, but if there is an independent interpretation, it's not going to get billed as the professional component of that test, because in this scenario, that's already been billed, but it is an independent interpretation that can count as data. We also have category 3, and this is going to be the discussion of their condition management or test interpretation. So you're going through that and what it means for that patient for their care plan. Oops, sorry. For high level of data, this is going to be where you must meet at least two of the categories. For category 1, you have to have three of the items listed in the bullets, and for category 2 and 3, those are going to be similar, but we're looking at the tests, which is going to require the three. We're looking at that independent interpretation and discussion and management of that, but you need to meet 2 out of the 3 for data. It's really counting what you did. And just remember, if you're ordering a test, the interpretation of that test is included in that order. So that would count as one if you're ordering it and interpreting it. So next, let's look at risk. Now, risk is one where we get a lot of questions, and there's a bit more gray area here. Okay, it's all going to be based on that specific patient. So here we're talking about the risk of complications and or mobility or mortality to the patient from the testing, the diagnostic procedures, the interventions, so the treatments and those decisions that are made as part of that care plan. That is, this risk is going to be based on the problems that are being addressed and managed in that encounter. Again, I'm coming back to that proof of thought for the practitioner when they're determining what we need to do for the patient for the conditions that they are treating or the problems that they're addressing that day. One of the things that we see here is we receive quite a few questions about, does this CPT or this diagnosis always mean high risk? Not necessarily. One of the things that we talk about is, even we'll get into prescription management just a little bit. It really does depend on what the patient has going on and what that decision means for that specific patient. There's not necessarily a right or wrong or a straightforward answer. So let's look at this a little bit more. So straightforward is going to be, there's minimal risk to the patient. There may be no risk at all with what's going on. So for instance, maybe you are saying, go home, you can take an over-the-counter pain reliever, and with your medical history, that doesn't pose any risk to the patient. That's going to be an example of a straightforward low risk type situation. The next one is going to be low. Now, here it's going to pose a little bit more risk to the patient. It could be that there's additional diagnostic testing that poses some risk. Maybe there's additional treatment. But again, you're looking at that patient situation to see what that risk looks like for them. Next, we have moderate risk. Now, some examples could include the decision for a minor surgery. Okay. Whether a surgery is considered major or minor, again, is specific for that patient and what they have going on. It's not just based on that global surgery when we're looking at risk. What's the risk to this particular patient for the surgery? A simple surgery, for example, someone's having gallbladder removal. So for an otherwise healthy patient, a laparoscopic removal is a pretty straightforward service, and it's not a big risk for the patient. However, if you've got a patient that's got other health issues, maybe they've got breathing issues, they've got heart issues, this same procedure could actually be a little bit higher risk for that patient. We've also included an AMA resource out here that will be helpful to you. We did, along with this, receive a question about possible treatment. Possible treatment at the next visit, does that qualify as a decision regarding minor surgery? So if it just says, this, we might do this type of a situation, that could count as moderate if it's a final decision on the surgery versus just a tentative idea or passing thought if that surgery is needed. It's about when that decision is being made. So something like that could be moderate, but it may not be. And this is where that documentation really comes in. The other thing that I want to talk about here is prescription drug management. We get quite a few questions regarding prescription drug management. They were all a little bit different. Some of them were asking, is this drug always a moderate risk? Uh, is this scenario always a moderate risk because it includes prescription drug management? So I'm going to answer all of them universally because it really does depend upon what's going on with the patient. So simply reviewing their prescription list or their drug list and renewing medication for that patient that they're already taking with no interactions, there's no adjustments needed, that's not something that qualifies as prescription management and moderate risk. That RX management is about the thought process of whether or not you need to continue the drug. You might be you'll need to lay out what drug are you managing for the patient. Are you changing the dose? Are you stopping a particular med because they're having an interaction? It can also be you considered a drug, but you're choosing not to prescribe the drug as part of that MDM. We have to see in the documentation what assessment was happening with that prescription. It's not simply renewing that drug. Um, it's not there's not a blanket statement or blanket guidance for these. It could be the patient has started to have a reaction, or maybe it's not working well and they need to change that dose. That's going to be an example of what prescription management looks like. And here the physician is responsible for assessing that, so that documentation is going to be key. They need to really clearly lay out what they're doing with those prescriptions. One example that we get often is prescriptions for over the counter. There are times where an over the counter drug could be a moderate risk for a patient. So, an example would be an NSAID for a person with kidney disease. Or if they're on an anticoagulant, that's a bigger risk than, say, someone without that medical history. But it's got to be clear in that documentation. And I know that gets a little confusing because CPT has it laid out as RX management as moderate. It's not, it's an example. It is not an always. Next is going to be uh, high risk. So high risk is going to be, again, based on what's happening for the patient. It could be there is a drug, or maybe the patient's in chemotherapy and there's a high risk to the patient. You have to monitor them for toxicity, and it's a pretty intense monitoring. That could be an example of high risk. We did get a question about certain IV treatments. Again, not necessarily always high risk. It depends on what's going on with the patient. Another example would be the decision for a major surgery. Could be an emergency, maybe it's a planned surgery. It could be the decision for hospitalization and escalation of care. One of the questions that we got was if a primary care provider sends their patient to the emergency department, is that always going to be a high risk? Not necessarily. It depends upon what's going on. Are they being sent to the emergency department because, yes, they need to be admitted as an inpatient or for observation? Could be high risk. Are they being sent to the emergency department because they need further assessment? That's not necessarily high risk because we don't know what's going on just yet. So it really comes down to that documentation. So speaking of that, we are going to go through the documentation. I know we're running just a little close on time. I don't believe we're going to be able to answer all the questions. I've seen some come into chat. I have been looking at those. We are going to do a follow-up document with that, but I'm going to go through documentation and we'll see how many questions we can get to. So with documentation, it's not a one-size-fits-all. We did get a lot of questions about what we need documented for particular codes, and it really depends. So here's what we're looking for. The documentation has to support the medical necessity for the services that are provided during the encounter. It has to include that proof of thought. That's that level of service. What is the cognitive load? What is the decision making? Or what's the time? what's going on with that patient when you're doing that. So you're going to want to include the evaluation history, the assessment of what's going on with the patient, can include the test results, the labs ordered, things of that nature. It will include the care plan. What are we doing to address the problems today, and what services have been provided? So it could be services provided that day, it could be services we plan to provide. We do need to have that accurate reflection of time and that proof of thought. Again, those problems addressed, that data analyzed, and the risk to the patient. We did get some questions on reviews. We did get one question asking about on a rack audit how they can be qualified to determine whether or not a level of service is correct? And the answer to that is our RAC audits, they do involve medical professionals and they're looking at that documentation. So it really comes down to that documentation supporting the level of service that's billed. Again, problem, data, and risk. And it needs to make sense. This is if it's MDM or time. So you have to look at the patient's needs and what are they doing? What activities are being documented? And again, does it make sense and support that code that's being built? So here we do have some resources. We talked about these. That chapter 12, I've also included that E&M services guide and then some documentation resources that we have available on our site. We've got just a couple of minutes. And unfortunately, actually, Ashley, let's see if we have time for one or two questions before I wrap up.
All right, I have been very busy in the chat with questions. Let me get to the last one that's not been answered. One moment, please. All right, the first question I have that has not been answered says, I have a question for risk. When the patient is sent to the ED for evaluation, not direct admission, escalation to hospital care is high, but has been communicated as direct admits from clinic. Where do you see clinic to ED for evaluation falling?
It's a great question. It kind of comes back to the example that I gave a little bit earlier. But if they're coming from the clinic to the ED, and if I'm understanding you correctly, the decision hasn't been made for that admission, it looks like, or it sounds as though it's further assessment. That's not necessarily automatically going to be high because the decision hasn't been made for that escalation in care. From what you're describing, that doesn't look like that would necessarily be high, but you'd have to look at that documentation um, to make that decision. All right, with that, I am seeing we are right pretty much at time. So unfortunately, everybody, I know Ashley's been trying to answer those questions, so I hope that we've gotten the answers that you needed today. We will be looking at the questions that we did not answer in chat today, and I will be creating a follow-up document and sending out to everybody on the call today so that you have those questions and answers. So with that, couple of things. If you're attending today for continuing education credits, in a couple of minutes, you're going to get an email that's thanking you for attending today. That is your certificate of achievement that can be submitted to your accreditation or certification body to count towards your continuing education credits or education units. So for some reason you didn't get that, one of two things happened. Your email went to your spam filter. The email comes from our WebEx Messenger and it may be in your junk or spam. It's something you may want to add to your safe sender list. The other is you attended by phone. In either situation, Ashley's going to put an email address in the chat for you. Go ahead and send an email with the topic of today's session and just say, hey, I need a certificate. Give me the phone number you attended from. Once I confirm that attendance, I will get that certificate out to you so that you have that. That email is also going to have a link to our survey. And as I said earlier, your feedback is super important to us. We do look at all of that feedback. Tell us what we did well, tell us what we could improve upon, and also please share with us the topics you'd like to see us in the future. We look at that and that we really do use that to decide what topics that we are going to offer. Couple of ways to take it. There's a link in the email. Ashley just put a link in the chat, and you're going to get a pop-up. You'll see the image here. That's not malicious. That's not spam. It is just telling you you're leaving our webinar software and going into our Qualtrics survey software or CMS's software. Again, questions, I am sending out that follow-up, but I will be taking questions for the next 7 days. So if you think of anything, if it is claim specific, it does need to go to customer service because they can access those specific claims. But if it's about choosing your level of service, I will be taking those for the next 7 days. Same education email box, and include that subject. That's going to allow those that are monitoring that know that Ashley and I need to get those so that we can get those responses for you. So with that, that concludes our session for today. I want to thank, on behalf of myself, Ashley, and the entire Provider Outreach and Education team here at WPS, I want to thank you sincerely for taking the time to attend. I know we're all super busy. Sometimes carving out this time can be very hard. Remember, we do have upcoming events that are going to drill a little bit deeper into the elements of MDM and time for choosing your level of service. So please consider registering for those. Also, if you have not, the interactive portion of this week's series is still open for registration, and if you're interested in that at all, that's out there for you as well. So again, I want to thank everybody for their time today. I hope to see you tomorrow. Otherwise, have a great rest of the week. You may now disconnect.